my style of the work when I start to study any new parts of the human body. Before speak about topographical anatomy, I try to introduce for you the importance of the region. In case of the abdomen, I think it is not so important because I think it's impossible to study in medical university and to not understand what the importance of the abdominal region. For example, from surgical point of the view, if your relatives will ask you what the importance of abdomen, what you will answer? Yes, come on, hurry up. What region of abdomen is important for us? Don't forget that the name of my subject, it is operative surgery in topographical anatomy. This is theoretical subject which is necessary for applied medicine, for the practical medicine. Friends, you are boring me. I will not interrupt my lecture any minutes to give you the chance to come in my lecture. Come sit down, next time I will remove you just from my class. No any idea. You're serious. You really seriously don't understand why region of abdomen is important for us? White coat, please. Or go outside if you don't have it. Well, my congratulations. You are the great. You are the best, my student. You are first, my student, who don't understand what the importance of abdomen. Fantastic. Of course, primary importance connected with surgical performances, which we can do in the region of the peritoneal cavity, in the retroperitoneal space. By the way, there are big group of the surgeries which we do just on the wall of the abdomen. For example, problems connected with hernias. Inguinal hernias, as you remember, that is the most usual form of the herniation of the human body. That's a friend, I think you understand what I tell you. I say, oh, put on your white. No, I will not give you chance. Go and go. Why 7 minutes late you must to come in my class? What does it mean? And you are so happy. You are really so happy. Guardian, Joteropeins anentat tatume. Anentat and tatume. Come sit down quickly. Put on your white clothes quickly. Let's say once again, sit down. Next time I will remove you. That is abnormal to come in the class without white coat. Come sit down. Close the door. There. Let's say we need attention. Friends, you waste now your time, you know. Despite will I explain it or no, I will give you it to study. And nobody will not come and say me why we didn't listen explanation. Because of this. Because any minutes you interrupt me and don't give me the chance to speak. So once again, listen, friend. Much more better. Where is your exercise books? Where is your hands? What does it mean? Absolutely zero level of the knowledge and you don't need to write anything. Let's say once again, listen to me attentively. Abdominal region, it is one of the most important surgical regions of the human body. Statistically, guys, listen what I tell you. From 45 up to 50% of all surgical performances, all, we make especially in this region, in the region of the abdomen. You understand? Half of all surgical performances we do in the abdominal region. Now, what the compartments of the abdomen? I think you know, maybe you listen, maybe you study during your anatomy that abdomen divided into two big compartments. One we call abdominal walls, and second we call abdominal cavities. That's how we have abdominal walls and we have abdominal cavities. Now, if you will look in this picture, for example, the horizontal section, yeah, transverse section approximately in the level of inferior margins of the costal arches. Anteriorly, near the title of our slides, you can see interior wall. Posteriorly, you can see posterior wall. And between them, you can see two compartments of the abdominal cavity. Look at, please, this compartment we call peritoneal cavity. Why it is peritoneal? Because from all sides it is covered by parietal peritoneum. And organs which is located inside of this compartment, covered by visceral layer of peritoneum. By the way, from anatomy you remember that organs cover differently by visceral layer. We have so-called intraperitoneal, we have so-called mesoperitoneal, and we have extraperitoneal or retroperitoneal structures. That's it. Once again, this is anterior wall of abdomen, number one. Behind of it, next compartment we call peritoneal cavity. Behind of peritoneal cavity, you can see some accumulation of the fat with some organs, for example, kidneys, biggest vessels. This compartment we call retroperitoneal space. And finally, last structure number two in this picture. It is posterior wall of the peritoneal cavity, abdomen, which we call also lumbar region. So now you can see four parts or four compartments of the abdominal region. Once again, from in front to behind. This is anterior abdominal wall, peritoneal cavity, retroperitoneal space, and the lumbar region. Lumbar region, otherwise we call posterior wall of abdomen. So remember this terminology, lumbar region or posterior wall of abdomen. Thank you very much. Change the slide, please. Now attract your attention into this picture. Today I will explain for you compartment number one of abdomen, which is called anterior abdominal wall. Now immediately in the picture you can see anterior abdominal wall, which is differently divided. And again, let's start from the importance of it. First of all, I must mention that this is the gate to the peritoneal cavity. 90% of its incisions, which is necessary to access the peritoneal structures, we made it immediately in the anterior abdominal wall. But it is not the single option why we need to know it. As I say you, in anterior wall by itself, we can have surgically treated problems. And the most usual, of course it can be traumas, for example, bleedings, for example, penetrations with eventration of organs to outside. Eventration, guys, it is protrusion of organs into outside by wounds. By wounds. That's why you must make differentiation between hernia and between eventration. As you remember, a week before, I gave you definition of the hernia. Then we studied the femoral hernias. We come to conclusion that hernia it is protrusion of organs through the weak places. By the way, these weak places divided into natural weak places and artificial. But anyhow, no any wounds. Then we speak about eventrations. We have the aperture. We have the wound, which is happened after some traumas, for example, car accident, part of the wheel, perforated anterior wall, for example, we have penetration of the wall, and organs come to outside, for example, intestine. Such kind of situation we call eventration or any hernia. And finally, as I said before, in anterior wall we can have several types of the hernias, most usually inguinal. In second position, it is the hernias of umbilical ring. In third position, it is hernias of white line of abdomen. In fourth position, it is the hernias of so-called Spiegel line. Spiegel line located in the level of the lateral margin of the rectus muscle. In the future, we will study. Next type of the hernias, it is hernias of Douglas line. Again, in the future, I will teach you what does it mean. Last type of the hernias, which we have here, it is the hernias of epigastral triangle. Again, I will teach you, I will show you. So you can see that very many different types of hernias. In absolutely different compartments of anterior abdominal wall. So you should be, how I can say, responsible in the future to take the scalpel and to make some surgical performance in anterior abdominal wall. And the base of this knowledge I will give you today. As usually, let's start from the borders of the region. If it is some topographical unit, we must to start its description from the borders. That is very usual for us, yeah? Anterior abdominal wall. It has approximately, as you can see the rhomboidal shape form. And it is divided into three groups of borders. Superior borders, lateral borders, and inferior borders. Let's start from superior borders. Look here please, from up to down. It is started from xiphoid process of the sternum, then it is passed along the costal arches up to the free margins of 11 ribs. Superior borders is finishing that level. Now let's come to the inferior borders. That's I explained for you upper angle of the rod. Now let's come to the lower angle of the rod. From two sides, right and left, I will have inguinal folds or inguinal ligaments. As you remember, the same structures, it is upper borders of the lower extremity. That's why inguinal folds and inguinal ligaments splitted your abdominal region from the region of the lower extremity. And finally, it is the pubic symphysis. So we describe now together the superior and inferior borders of our region. Yes or no? Now, from the sides, guys, I will provide it now imaginary lines. I can do it in two different ways. Now, way number one. I will take the free margin of 11 ribs, 11 twelfths, and will connect it vertically to downwards by the level of anterior superior iliac spine. Or, in another way, I can take the middle axillary lines, which we study together in the thorax region, and I can continue it down immediately up to its crossing place with the anterior superior iliac spines. That's in both ways, or I can use imaginary lines, or I can use the exactly connection between anatomical structures which we have in anterior abdominal wall. So you can see that I draw for you rhomboidal shape region. So two superior borders, two inferior borders, and two lateral borders. Yeah, which, by the way, these lateral borders immediately will divide your anterior wall from your posterior wall. Is it understandable? I think it is not so hard. I think it is not so hard. And what we do usually after the description of the borders, we start to divide the region into sub-regions. Because, as you understand, yeah, a region is very big. Now, because you are seated in my place, I will ask you the question. Tell me, please, why we describe borders, I think it is understandable. Because borders show for you how much some topographical specificities will be spread. Because, as you understand, the rules which will work in abdomen will not work in the lower extremity. But tell me please, why we need to make subdivision of big regions into small subregions? What is the meaning of this? Why I cannot, for example, explain topographical anatomy for all these big compartments at once? Why I make complicated your life? Why I speak about divisions? You must remember a lot of imaginary lines, I don't know, subdivisions, for what? To make really your life little bit hard. So what the meaning of this?
Because each region has many big arteries.
And what? Okay, each region has any big arteries. That is the cause why I divided the region into subregions. Well, you forget totally, guys, my previous semester, because in previous semester I explained completely why it's necessary. Please, I listen you. Your options. Friend, you are without white coat or you without your gray matter? Why you sleep now? What about I asked just now? What is my question?
divide the main big region into sub-regions.
What is your option?
Because we have all the every regions we have like some in your lines.
That's why I make this division just to make for your life a little bit hard. So what is the meaning of this? Why, friends? Let's make now some improvement of my subject. Let's describe all these big compartments at once. And for you it will be simple, and I will economize my time. Why I make these subdivisions? Why, for example, lower extremity, we don't study like one big bulk. Why we divided it in femoral, knee region, leg region, ankle joint region, foot region? Of course. I want to remind you the methods of investigation of my subject. Holotopy, syntopy, skeletotopy, and stratigraphy. From this 4 point of the view, inside of big region, I can have absolutely different subregions. For example, let's take the last point, which is called stratigraphy. As you remember, that is the part of my science which is study the region layer by layer. Yeah. Now imagine the situation. You study thigh region together with knee region, and you want to describe the stratigraphy, for example, specificity of the skin. Will you have complications if you will describe both of these regions together stratigraphically? Yes or no? Why?
Because the skin of thigh is different from.
Super answer. Sorry if I have completely different type of the structures. How I can make this description? Even in thigh region, anteriorly, posteriorly, I have different. Even medially, laterally, I have different skin. So usually I mention these specificities, yeah, then I describe the region. Same in here. I must make subdivision to have inside of each compartment some specific qualities. Of course, I will not after describe for you each from these 9 compartments separately, but about specificity of the during my text I will mention, of course. How we make this division, you know. You studied from anatomy, if I don't mistake. You spoke about 2 horizontal lines and 2 vertical lines. By the way, horizontal upper line, that one, we call bicostal line. Horizontal lower line, we call bispinal line. Only by these 2 horizontal lines, we divided the anterior wall into 3 sections. Upper, middle, and lower. Upper one we call epigastral, middle one we call mesogastral, lower one we call hypogastral. By the way, how we provide these lines also is not the big puzzle. Bicostal connected lowest points of costal arch to each other. Bispinal connected right and left anterior superior iliac spines to each other. So I think it is not hard to remember. Now you must provide it 2 vertical lines. How you do it? Again, in both 2 ways. Way number 1, which is more simple. Yeah, you can find your midpoint of the clavicle and to provide it middle clavicular lines up to your pubic bone. Say middle clavicular line, that is thoracic imaginary line, but you can use its continuation to make some divisions in anterior wall. Second method is not so simple because you should palpate the lateral margins of rectus muscle. For some people it will be easy, for big people it will be not so easy because fat will close the muscles. But anyhow, middle clavicular line coincide with the position of the lateral margins of the rectus muscle. So you can do it in both ways. And finally you can see 9 compartments. 3 in epi, 3 in meso, and 3 in hypogastral region. One of the most important information which I want to give you about this division, it is projection of the internal organs into anterior abdominal wall. For example, if I don't mistake, I put here the picture which shows these projections. No. Unfortunately, no. But anyhow, you can simply imagine it, yeah? Now, 1 minute, look to me. Let's start from upper floor. Let's say epigastral region, we divide it into 3 parts. Right and left hypochondric region, below the ribs hypochondric region, yeah? And between them proper epigastral region. Remember, please, in epigastral, these three compartments, we don't project it the small intestine. Small intestine start to project it into the anterior wall from meso and hypo. By the way, in whole meso and in whole hypogastral region, we will have projection of small intestine. But in epigastral region, no any projection of small intestine. That's a consequently, let's start to project the structures. Right hypochondric region, right lobe of the liver, together with the gallbladder. From retroperitoneal space, it will be upper pole of the right kidney. It also will be projected in this region, yeah? Now let's come to the left compartment. Here will be the spleen. Here will be the upper pole of the left kidney. And here in the left region, we will have greater curvature of the stomach. Partly it will be projected in this region. Now let's come to the proper epigastral region. Of course, projection of the main part of the stomach. Of course, projection of the left lobe of the liver. Yeah? Of course, projection of biggest vessels in right side aorta abdominalis, in the left side, in the right side inferior caval vein, which is located in the retroperitoneal space, yeah, and pass to downwards. They will be projected here also. And upper part of the duodenum, it is superior horizontal part of the duodenum, it also will be projected in this region. Now let's come to the mesogastral region. As I say, you totally small intestine. Now the first region in right side we call right lateral abdominal region. In right lateral abdominal region we will project it inferior pole of the right kidney. We will project it here the ascending colon and partly left knee of transverse colon, which is located. By the way, we forget to say that in hypochondric regions we will describe two knees of transverse colon, but the transverse colon will not be projected in epigastrate because it has a loop-shaped form. It is come to the middle compartment. That's why knees will be inside of hypochondric regions, but the main part of transverse colon will be mesogastric, which I will explain you after. That's once again ascending colon and part of the ureter, which is started from the pelvis and descended to down. Approximately it is projected by the lateral margins of the rectus muscle. Now let's come to the middle region. Oh, sorry, let's go symmetrically to the left lateral abdominal region. Here we will have descending colon. Here we will have inferior pole of the left kidney. Here we will have small intestine as everywhere. And we will have the left ureter, which also will be projected strongly by the lateral margin of the rectus muscle. Between right and left lateral abdominal regions, we have umbilical region. Usually you make mistake. You think that umbilical region and umbilical ring, it is same. Of course it's not same. Umbilical region, as you can see, is very huge. And midpoint of this umbilical region presented by your belly button, by your umbilicus, but not whole of this region. So what we projected here? Here we projected main part of the duodenum. Here we projected the head of the pancreas. Here we projected inferior part of the greater curvature of the stomach. Here we projected transverse colon, because as I say, it has the loop-shaped form and it is descended to the. Of course, here in this region we projected also the small intestine, because as I say, except proper epigastral region, in all another compartments we have the projection of our small intestine. By the way, I forget to say that tail of your pancreas will come to the left hypochondric region. So your pancreas passes from downwards to upwards, from right side to left side. That's a head and body of the pancreas, mainly located in umbilical region. Tail of your pancreas reach the left hypochondric region. As you remember, it is touched to the hilum of the spleen. Between tail of pancreas and hilum of the spleen, we have 1 centimeter distance. So remember about it. Now let's come to the hypochondric region, right hypochondric region. It is thickened together with the appendix vermiformis. Of course, it is the inferior portion of the right ureter, and again, of course, it is the small intestine, yeah, which is projected everywhere. Inside of the wall of the right umbilical region. We have right inguinal region, sorry, we have inguinal channel. Inguinal channel, it is not the cavity structure, that is the wall structure, but it will project it exactly in the right inguinal region. About inguinal channel, we will speak a little after. Now let's come consequently to the left side. Instead of the cecum, we will have sigma here. Again, we will have inferior portion of the ureter. Again, we will have small intestine, which is projected in this region, yeah? And again, inside of the wall, we will have now left inguinal channel, which is also projected in this region. Now, we come to the middle portion, inferior, that one, which we call suprapubic region. And here we will project it the lowest portion of the small intestine. Lowest portion of the right and the left ureters, which is connected with the urinary bladder. Then the urinary bladder full by the urine. We will have here the fundus of the urinary bladder. We will have here the fornix of the uterus for the females, yeah, up to the level of the cervix, yeah, especially for the females with the deliveries in the anus, yeah, because it is enlarged the uterus and push it into the peritoneal cavity. And of course we will have in two regions, guys, in umbilical region and in suprapubic region, we will have projection of the greater omentum, which is covered from anterior side, the loops of the small intestine. Yeah? It is started from transverse colon and descended to down and cover approximately 70–80% of the small intestinal structures. That's all. This is the projectional specificities. In the future, guys, you will use these projections to make access. Because of course the shortest way to find the organ, it will be the projectional way. Using this, not only for that you will use projections. Usually, friends, in the place of organ projection, we will have the localization of the pains from the organ. And it is connected with specificity of the vegetative innervation. It's an organ pain projected in the place of projection of the organ into anterior abdominal wall. So it will help you to recognize some pathological condition. For example, pain of proper epigastrium will be usually originated from stomach problems. Pain, for example, in right hypochondric region, it can be gallbladder. It can be, for example, liver problems. So according to the location of the pain, using the information about projection of structures, you can speak about some symptoms of pathological disorders connected with different organs. Now let's continue and let's come now immediately to the stratigraphy, otherwise the layer studying of anterior abdominal wall. Right, please, layer number one, skin. Make only short, brief notes, because majority of the problems is written here and you don't need to write everything. Layer number one, skin. Minute attention to me. One of the most elastic and movable skins of the human body. There are one exception only. It is umbilical ring. Inside of umbilical ring, skin doesn't have not elasticity, not the movement. Why it is so? Because skin inside of the ring fused with deep layers, scar is formed here, then we lose umbilical cord. All the layers which we have inside of this ring joined to each other, fused to each other, because the scar, what is scar? It is connective tissue. And that's a skin inside of the umbilical ring lose its elasticity and lose its movement. In all another parts, we have elastic and we have movable skin. This is necessary for physiological conditions, especially for the females. That is one of the most important conditions for the pregnancy. Because you understand that the organs will be protruded, to in front, and if the skin will be not elastic and non-movable, it will be impossible. Males also use this. As you know, guys, we have abdominal breathing. So to make the deep breathing process, we can use abdominal muscular constriction and dilatation. And usually females have the thoracic breathing, but males have mixed one. We use a thoracic because we are made more physical activity, usually. Not all males, of course, but anyhow. Let's say these respirational movements involve the belly movement also. And we must have here elastic skin. Skin in the lower compartment, especially in the hypochondric region, especially hypogastric regions, has a lot of sweat and sebaceous glands and hairs. By the way, guys, about hairs, which is covered usually our lower compartments, yeah, near the genital organs. Here there are the dimorphism, difference between males' hairings and females. For the females, guys, usually it is upper border of the hairs, it is horizontal line, which is located approximately in midpoint of suprapubic region. For the males, it is oblique ascending line, which goes to the level of umbilicus. So it doesn't finish horizontally for the males. It is obliquely continuous along the midline up to the inferior margin of the umbilicus. You can say why I tell you about it. Because you can recognize, for example, endocrinological disorders, yeah? For the males and females, if you will see that the upper border of the hair coverage is changed, for example, for males by female type, or for females by the male type. You can make some recognition. What else I can say about skin of this region? More you will go to downwards, the more elastic and movable will become the skin of anterior abdominal wall. So remember, upwards it's also elastic, but not so much like in the inferior compartment. This is also important to remember. Layer number 2, which you can see in the picture, it is subcutaneous fatty tissue. One of the greatest developed fat in the human body. There are exceptions. Again, it is umbilical ring. Inside of umbilical ring, fat is absent. I think you understand why this ring has form of depression, because no fat. By the way, the more bigger will be the person, the more deeper will be umbilical ring, because big bulk of the fat will be absent. So what is happening here, guys? Now look to me. For example, here's the white line, which is located between two rectus muscles. Yeah, a little after we will speak about formation. I am the skin. In the region of the umbilical ring, these two structures will be joined to each other, fused to each other. And we will not have any fat between them. Again, 2 minutes before I told you about the meaning of it, why it's happened. Because we have scar. Then we lose umbilical cord, layers which is located in that region, fuse to each other. And by the way, not only fatty tissue, deep loose connective tissues also will be closed here. Let's continue, but in all another parts, fat is great developed. And again, the same rule. The more down you will go, the better fatty tissue will be developed. So upwards it's also good developed, but the more down you will go, the more better fatty tissue will be divided. By the way, inside of the fatty tissue we have superficial fascia. And superficial fascia split our fat into 2 layers, superficial layer and into deep layer. But 1 minute attention. In the lower compartment of anterior abdominal wall, superficial fascia presented by 2 layers. That's what is happening, guys. 2 layers divided fat, not into 2, but into 3 layers. One is located between skin and superficial layer. Second located between superficial and deep layers. And third is located between deep and proper fascia. Idea is understandable for you. That's why remember, please, this is very important. In upper and middle compartments, fat has double layer, superficial and middle. In the lower compartment, fat has 3 layers, superficial, middle, and deep. By the way, write, please, superficial fascia in the lower compartment of anterior abdominal wall, split it into 2 layers. Superficial layer we call Camper's fascia. Camper, it's written here, Camper's fascia. Deep layer we call scarp fascia, or otherwise Thompson's fascia. Both names is used. Deep layers we call scarp fascia or Thompson fascia. And minute attention now to me. Now imagine that my white coat This is superficial fish. As I say you, in the lower compartment, it is split into two layers. Yeah? For example, my shirt will be deep layer, white coat will be superficial layer. How they continues to down? Superficial layer, as now immediately you see, continues to the region of my lower extremity. And in the lower extremity, it is become to superficial fascia of the lower extremity. Yeah? Without interruption, it is goes to down. But what is happened with scar or with Thompson fascia, minute attention to me. The scar fascia, guys, minute attention to me, continues to down, reach the level of inguinal ligament. What is it? I will tell you after. Yeah? Fuse with the inguinal ligament and continues to the region of the genital organs and cover genital organs as superficial fascia of the genital organs. It doesn't go to the lower extremity. So once again, remember this important information. If superficial layer of superficial fascia without interruption continues to down and cover your lower extremity, deep layer of superficial fascia reach the level of inguinal ligament, fuse with inguinal ligament, and continues to the genital organs, continues to the region of perineum, and cover it. Is it understandable? Now imagine the pathological process inside of subcutaneous fatty tissue. For example, I will be superficial layer, he will be deep layer, and we will have three compartments of the fat. Superficially to me, superficial compartment, between us, middle compartment, and behind of him, deep compartment. Now, what we must know about superficial one? You know what is the importance, guys? I gives a lot of sectors, which is goes to the skin and fuse with the skin. The superficial compartment of the fat has pocketer structure. Now, imagine that inside of this superficial compartment there are pathological liquid. For example, pus. Which form it will have? Local. That's why remember, please, forever, in superficial compartment of the fatty tissue, pathological process cannot be widely spread because it is divided into the pockets. So if you see that pathological process in fatty tissue have the form of the lamp, you understand that it is located in superficial layer. You can say it in what? You understand how deep you must to cut the structures. For example, for drainage of the pathology. Because, for example, the problem is located in superficial layer. Yeah? If I will cut more, for example, if I will damage, for example, superficial and deep layers, I will mechanically spread this pathological process to deep. Now look to me. If pathological process located between us, it means in middle layer. No any septus we don't have here. But minute attention to me. How much the problem can be spreading? It can go simply from abdomen to the lower extremity. Why? Because superficial layer of this fascia, as I say, yeah, without interruption, continues to down. Sliding by its direction, pathological process will immediately go from the abdominal region to the lower extremity. So if you will see that pathological problem is not separated, it has the form of the phlegmons, and from upwards by gravity forces, it is descending to down. You understand that it's immediately located between two layers of the superficial layer. Now, lastly, problem located behind of him. Yeah, it means between deep layer of the superficial fascia and between proper fascia. How it can be spreading? Can it go, for example, to the lower extremity? Of course no. Because he, deep layer, come to the inguinal ligament, fuse with the inguinal ligament. That's a deep layer of the fat separated from the lower extremity. Now imagine that my hand, it is deep layer. I come and join to the inguinal ligament. Of course, the space which is located behind of it will not have any communication to that. How the problem can be spread? Obliquely along the direction of the inguinal ligament up to the genital organ. That's why remember, guys, only the knowledge from topographical anatomy will help you to recognize the layer of location. Remember, please, if you recognize the place of pathological process, means 50% of the problem you will resolve. You understand how much you can cut, open, drain, and anything else. Let's say remember this. This is very important. You can write or you can remember. I think it's not necessary to waste time and write it. Just remember, please, that only in hypogastral region, fat has 3 layers. You can say me how many layers it has in upper 2 regions too. Because in upper 2 regions, superficial fascia presented only by 1 layer. It is split into 2 layers only in hypogastry. So how will be spreading the problems in upper 10? Simply, if it is superficial layer of fatty tissue, it will be pocketed, problem will not be spreading. If it is in deep layers of the fatty tissue, it will be layering. It will spread it from up to down. And what will be happen for this pathological process if it is spreading from up to down? Again, along the inguinal ligaments and along the genital. Why? Because this single layer, look here please. Now this is single layer in upper and middle third, yeah? Fat is divided into superficial and deep. Then, in the border between middle and lower third, it is split into 2 layers. So pathological process which is primary in upper third located in deep layer immediately will go behind of the last layer of division into the inguinal region and into the genital organs. It cannot be spread into the downwards. Do you understand it or not? That's right, please. In the deep layers of subcutaneous fatty tissue, why I say layers, because as you understand, in lower third, there are 2 deep layers, yeah? Middle and deep. We have superficial vessels and nerves. We have superficial vessels and nerves. Let's start from superficial nerves. Right, please. This is the superficial branches. This is the superficial branches of intercostal nerves. This is superficial branches of intercostal nerves. Open the brackets and write, please. 7 inferior intercostal nerves. Doesn't finish in the level of thorax. And they continues to the anterior abdominal wall. It is 6 inferior intercostal nerves. 7, 8, 9, 10, 11, and 12. Not only nerves, intercostal neurovascular bundles, yeah? 6 inferior intercostal neurovascular bundles. They continues from the region of the thorax to the anterior abdominal wall. Open the brackets and write, please. Main trunks of these neurovascular bundles is deep. They are located between muscles. But each nerve gives the superficial branch, which is come to the deep layer of fatty tissue and innervated the skin. Once again, main trunks of these 6 inferior intercostal neurovascular bundles located between muscles, which we will describe after. But each intercostal nerve from these 6 mentioned gives the superficial branch, which is coming to the skin and which is made segmental innervation of the skin of anterior abdominal wall. Segmental. Open the brackets and write, please. 7, 8, 9 are located above the region of umbilicus. 10, 1 located in the level of umbilicus. And 11, 12 located below the level of umbilicus. So they make segmental innervation of anterior abdominal wall. Friends, the same segmental innervation we have, of course, in thorax region, yeah? That's a consequently, these 6 inferior neurovascular bundles, like my fingers is 5, but you can simply imagine, yeah, that 6 inferior doesn't finish in the thorax. By common direction, they descended into anterior wall. That's a 3 is located above the level of umbilicus, 1 is located on the level of umbilicus, and 2 is located below the level of umbilicus. Remember it, please. Also write, please, inside of subcutaneous fatty tissue, we have superficial vessels. By the way, not only veins, as usually, but arteries also. Open the brackets and write, please. This is 3 arteries which is started from the level of the femoral region. And they all these three originated from femoral artery. Write the name, please. Arteria epigastrica superficialis, arteria circumflexa ili superficialis, and arteria pudenta externa. Once again, friends, you see three arteries. We study all these arteries. By the way, you can see it in this side. Opposite side of the picture show for you the deep layers, that is muscular layers. But this side of the picture show immediately the fatty tissue. That's it. This transparent structure which you see, it is the deep layer of superficial tissue. So you can see vessels which is located in fatty tissue. All of them, as you can see, come from the level of the hiatus saphenous. Yeah? As you remember, they originated from femoral artery. Immediately, several days before, yeah, we studied, we spoke about it. How we projected these neurovascular bundles. Now, pay attention to me. You take inguinal ligament, you divided it into three equal parts, upper, middle, and lower. And from the border between middle and lower third, one line you provide it after umbilicus. It is projection of epigastrica superficialis. Second line you provide it to anterior superior iliac spine. It is circumflexa ili superficialis. And third one you provide it to the pubic tuberculum and symphysis. It is pudenta externa. Let's say, remember, please, inside of the fatty tissue we have arteries and veins, not only the nerves. And that is the three pairs which is originated from femoral blood. As you remember, when I described these vessels in the lower extremity, I told you that they doesn't have any functionality in the lower extremity. They start to supply the structures only in anterior abdominal wall. Is it understandable for you? Continue, please. Layer number 4, it is the proper fascia. Very bad developed structure in the anterior abdominal wall. It is very bad developed structure in the anterior abdominal wall. Open the brackets and write, please. Anatomically it exists, but surgically it doesn't have any importance. Surgically it doesn't have any importance. What does it mean, friends? Pay attention to me. Of course, if the histologist will take, for example, the specimen from this wall, histologically, microscopically, he or she will find this proper fish. But then you make surgery, macroscopically, you don't find it. So slim is it. They said for us, from surgical point of the view, that is non-recognizable structure. So we don't speak about any its importance. Look, remember, so great it is developed, for example, in the lower extremity, the upper extremity, but not here. Function of the proper fascia, in the future you will see, will form here the aponeurosis of oblique muscles. For example, they will cover the rectus muscle and will form the sheath for the rectus, not the proper fascia, but aponeurosis of oblique muscle. That's all right, please. Immediately, next layer, it is the muscular layer. Muscular layer. Open the brackets and write, please, muscles in anterior wall divided into two big groups. Lateral group, which is presented by oblique muscles, which is three, as you remember from anatomy: external oblique, internal oblique, and transverse abdominal muscles. They have a lateral position. And the medial group, which is presented by two muscles, it is the rectus abdominis muscle, and this is musculus pyramidalis, pyramidal muscle, which can be absent. For example, in half of the cases, it can be absent. But let's start from first group, oblique muscles. Now write, please, muscle number 1, external oblique abdominal muscle. This is the most superficial oblique muscle. From upwards, it is started from anterior surface or external surface of the lower 8 ribs, from the 5th one up to the 12th. From external surface of the lower 8 ribs. From backwards, from back, it gives the fibers which is fused with the spinal processes of the vertebra. From downwards, below bispinal line, from downwards, below bispinal line, muscle become to aponeuros. This aponeuros fused with anterior 2/3 of the iliac crest, anterior 2/3 of iliac crest. In the brackets, right, please, it means it fused with anterior superior iliac spine. From the backwards, it is fused with the base of the sacrum. And from in front, it forms the aponeurotical structure, which we call inguinal ligament, by junction with pubic symphysis and tuberculum. By junction with pubic symphysis and pubic tuberculum. 1 minute detention. Last time I spoke about it, then we discussed femoral hernias, but once again I will show it for you. Now imagine that my right carotid is external oblique. As I say you, below the bispinal line, muscular fibers, which is usually, have pink, red color, as you see in the picture, become to the white color, yeah? They forms the aponeuros. You know that what the main difference between aponeurotical and muscular part of the muscles. Muscular part can be constricted, aponeuros no. So functionally, aponeuros, it is non-active part of the muscles. Aponeuros is forming the place of the junction of the muscles, for example, with the bones. That's what is happening with this aponeuros. Look to me. In the inferior parts, it is fused with anterior 2/3 of the iliac crest, with the anterior superior iliac spine. Then it is continuous to my pubic bones. In the level of the pubic bones, by the way, it is split into 2 legs. Lateral one fused with tuberculum pubicum, medial one fused with the symphysis pubica. And in the same, that's what is happening, guys. Now look, she is anterior superior iliac spine, I am the pubic bone. This aponeuros, which will be continuous between us, will be called inguinal ligament. But this inguinal ligament, guys, it is not the single layer, but double layer of this aponeuros. They say aponeuros, you can write to remember, along the inguinal ligament, make duplication. Instead of 1 layer, it is just make the fold. It is turned to the backside. And it forms the duplication, and immediately this duplication between anterior superior iliac spine and the pubic bones we call inguinal ligament. So now you understand what is the origin of our inguinal ligament. It is originated from aponeuros of external oblique abdominal muscle. That is just only duplication of this aponeuros. Twice thicker. Do you understand it? Normally the length of this inguinal ligament approximately 12 up to 14, 15 centimeters. By the way, for the females it's longer than for the males. Why this happen, guys? Pay attention to me. Now imagine that my 2 hands, friend, don't sleep. I will just now remove you from my class. Imagine that my 2 hands, it is anterior superior iliac spine. Of course, you understand that for males, they will be near each other because the pelvis is narrow. For females, vice versa, pelvis is wider, so my hands will be far from each other. But more far they will be from each other, more will be distance between my hand and pubic symphysis. So this is the case why for females it is little bit into 1-2 centimeters wider than for the males. And in the future you will see that it will influence into the incidence of formation of inguinal hernias. For the females it will be lower than for the males. Because for the females, look here please, your inguinal ligament will have more horizontal position. It will be longer and it will be more horizontal. But above this inguinal ligament, little after years, that we have space, which is called inguinal space. And this immediately leads to space. But sorry, more higher will come to your inguinal ligament, the more smaller will become to this space. And you remember the rule which I say you in my previous lesson. If the weak space small, possibility of formation of hernias will be not so much. And vice versa. The more will be the size of weak place, the more will be the chance of formation of the hernias. That is the case why near to 70-75% of inguinal hernias belong to the males. As you remember, 90% of femoral hernias belong to females. So what is happening? Meaning attention to me. Your inguinal ligament ascended to up. Space which is below inguinal ligament is enlarged. Space which is above inguinal ligament, it is decreased. So then for females, ligament goes to upwards. Deep ring of the femoral channel is increased, but inguinal space is decreased. There's a femoral hernias, that is the problem of females. Inguinal hernias, that is mainly anatomically, structurally, that is the problems of the females, sorry, males. And this is understandable for you. Now write the name of the small picture, formation of the inguinal space. And minute attention to me. Now put the point in the upper part of your paper. Put the point B and C in the lower part of your paper. Now please, from point A to the point B, draw the line and finish it 1-2 centimeters above the point B. On the level of point B, split please this line into 2 legs or branches. And near of one, draw please number 1. Near the second, draw number 2. Now let's start to mention names of this structure. A, right, it is anterior superior iliac spine. B, it is tuber pubicum. C, it is symphysis pubica. And between them, of course, we have the bone. It is the upper branch of the pubic bone. Picture is understandable for you guys. Now write please, number 1. We call lateral leg of inguinal ligament. Lateral leg of inguinal ligament. Otherwise we call it inferior leg. Number 2 we call superior leg of inguinal ligament. Otherwise we call it medial. Number 1 it is lateral or inferior. Number 2 it is superior or medial. You see aperture between structure 1 and 2. I want to remind you your anatomy. As you know, it is the future place of formation of external ring of inguinal channel. Which another structural units I need to completely finish this external ring? Now write please, in upper portion, between a ligament number 1 and 2, there are the fibers. Write please, this is fibers number 3. We call it intercrural fibers. In the Latin we say fibra intercruralis. They make round upper angle of this aperture, yeah? From triangular shape, they provide it to the oval shape form. One more ligament we have in the lower portion of this aperture. Again, it makes the more round, the final picture of this aperture, and connecting two legs to each other. In my picture, this is the fourth structures. And we call it ligamentum reflexum, or by the author, we call it the Golez ligament. It is connected these two legs to the pubic bone and make this junction more strong. Now attract your attention into structure D, which is located between this drawn structure, and write the name of it. We call it the superficial ring or external ring of inguinal channel. If in your controls on your exams you will have question, how it forms, you can see four structures. Number 1, 2, 3, and 4. These four structures together forms the superficial ring of our inguinal channel. We don't have the channel, I don't draw the channel, but we have in this level now the ring of it. By the way, I can draw for you the communication of this channel. I will clean this B and C. Now look at please, immediately below this channel for the males, I will draw the big sac. I think you understand what sac is in. That is scrotum. Let's say this will be structure number 5 in our picture, which is called scrotum. Now open the brackets and write, please, by superficial ring, inguinal channel communicated for the males by the scrotum. What about females? A minute attention, please. For females, no any communication. It is come to the level of the pubic bones and bluntly finish in this level. As you remember, for females, by this aperture, round ligament of the uterus become to the bones and fuse with them. For the males, situation is another. What is passed by this ring for the males? What is the main structural unit which by this ring goes into the scrotum? Great answer. Super answer. Look here, please. Let's draw the testes inside of this scrotum. And through this aperture, let's provide it some big structural unit which is come to the scrotum and fuse with the scrotum. How I call this? Spermatic cord. It's not a single structure in the channel, but it is the main structure in the channel. So you can mention this structure like the 6 structures. It is the spermatic cord. So remember, please, for the males, the main function of this aperture, it is the communication between inguinal channel and scrotum, and passage, please, for the spermatic cord. Let's continue. Now we need attention to me. Before draw for you another structural units, everybody please attract your attention into the next picture. Now we need attention to here. On the external oblique muscle, as you can see, the window is performed. And through this window you see another oblique muscles. Immediately behind the external oblique, you can see internal oblique muscle. Under internal oblique, you can see transverse. I think you recognize what it means. Now look to me. External oblique is cutted. Behind of external oblique, you can see internal oblique. Then behind of internal oblique, you can see transverse abdominal muscle. I think it is greatly visible. Now, find the place of right, please. Internal oblique muscle from upwards fuse with the inferior margin of the costal arches. From backside, it is originated from proper fascia of the lumbar region. And inferiorly, it is fused with the superior 1/3 of inguinal ligament, or lateral part of the inguinal ligament. Look here, please, guys. In the picture, in the text here, I write that it is fused with the lateral half of inguinal ligament. But in reality, it is not completely half, but it is the lateral 1/3 of inguinal ligament. That's like, by the way, here also there are the problem in the, as the surgeon I will tell you that this is in reality not immediately health. It is much more lateral 1/3. But again I say you, in different literature it is written in different ways. They say right health, but understand that this is not the real health. This is much more lateral 1/3. Now quickly write about the last muscle. It is the transverse abdominal muscle. From upwards, it is fused with inner surface of 6 inferior ribs. Posteriorly, it is continuous to the deep layer of proper fascia of the lumbar region. You see, last 2 muscles originated from proper fascia of lumbar region, internal oblique and transverse. By the way, for internal oblique, right, please, it is originated from superficial fascia of proper fascia of lumbar region. For transverse, from deep layer. By the way, here there are some casus which is confusing, guys. Now look, when you describe back region, lumbar region, superficial layer, we call posterior layer. Deep layer, we call anterior layer. So it is mixed usually. In anterior wall, vice versa. Superficial layer is anterior, deep layer is posterior. So don't be confused. Let's say in the back, superficial layer will be posterior, deep layer will be anterior. Let's say from deep layer originated transverse fascia, the transverse muscle, otherwise deep layer we call anterior layer. From superficial layer, which we call posterior layer, internal oblique muscle is originated. And again, right, please, downwards as the previous muscle. It is fused with the lateral half of the inguinal ligament. Again, I say half, but I understand mainly upper 1/3. Is it understandable for you? Now look to me. Let's continue our picture. And let's divide our inguinal ligament into 3 equal parts. Upper 1/3, middle 1/3, and the lower 1/3. And mention please the point which is located in the border between upper and middle 1/3. Is it understandable for you? Well, repeat it, please. What I say just.
That's upper and middle.
So we put the point between upper and middle. Now look what I will do now. I will draw, by the way, muscular fibers of these 3 muscles have different directions. For external oblique, it is from up to down, from laterally to medial. For internal oblique muscle, it has the fun direction. Upwards, upper portion from down to up, middle portion horizontal, lower portion as the previous muscle from up to down. So if you will put your middle finger in the level of your umbilicus and widely open your fingers, it will show a direction of the internal oblique muscle. Transverse, I think you understand, it has only horizontal direction. So remember, please, external oblique pass from up to down, from lateral to medial. Internal oblique differently in different parts. Upper part is ascending, middle part is horizontal, lower part is descending. And finally, transverse by the name. It has transverse fibers. Before I will start, I will continue to do my picture. Now look immediately at the beginning. All these 3 mentioned muscles, after you will write it, that is very important, but first listen. All these mentioned muscles in the level of the lateral margin of the rectus become to aponeurosis. And medially to this lateral margin of the rectus, we have only aponeurotical fibers. Attract your attention into the picture and find this horizontal passage point for all these 3 muscles, and for external, and for internal, and for transverse. You can see that approximately for all these muscles, I'm very sorry, this line will be in same level. This is for external, this is for internal, and this is for transverse. So as you can, but for external, there are another passage place. It is by spinal line. The external oblique muscle pass through aponeuros by 2 lines, one vertical, one horizontal. Another 2 muscles pass through aponeuros only by 1 line. It is the vertical line. Look here, please. if below this line you don't have external oblique, behind of it, I will show now to prove you. Unfortunately, all my pictures is finishing that level, but believe me, below this level, you will have up to inguinal ligament and internal oblique and transverse. Just now I told you that both these last muscles fuse with lateral 1/3 of the inguinal ligament. What does it mean? It means they reach the inguinal ligament. But remember, once again, I say you, all these oblique muscles, write it now to remember, all 3 oblique muscles near the lateral margin of rectus, usually 1 centimeter laterally to this lateral margin of the rectus, become to aponeurosis. All these oblique muscles near lateral margin of the rectus become to aponeurosis. In the future, you will see that this 3 aponeurosis forms the sheet for rectus muscle. But now let's continue our picture. Now let's draw what I told you before. Now look everybody to me. I drew the fibers of muscles, partly descending, partly horizontal. Fibers of muscles, which is fused only to upper 1/3 of inguinal ligament. But look please to me, it doesn't fuse to the inferior 2/3 of inguinal ligament. You see, let's say put here the number 7 for all these fibers. And write please the muscular fibers of internal oblique and transverse abdominal muscles. Muscular fibers of internal oblique, it will be descending, and transverse, it will be horizontal. Unfortunately, I'm not the so good painter to show for you both of them. If you want, for transverse, I can draw for example this intraocular line, horizontal line of the fibers. But immediately attract your attention please to this space. Let's put here the letter E. How I should call this space? Inguinal space, of course. Let's say write please inguinal space, space E. It is the distance between free margin of internal oblique and transverse and the inguinal ligament. It is the space between internal oblique and transverse, free margin, and inguinal ligament. I think it is so simple, friends. Space E, look to me, from upwards, it is bordered by inferior margin of these 2 muscles, 7. From down, it is bordered by inguinal ligament. Why your face is so confused? So look, if my roof will be inguinal space, my roof will be free margin of these 2 muscles, my floor will be inguinal ligament. I will be inside of this space. Now you can say me, why inside of this space we can have formation of hernia? Simply look in the picture, because these 2 muscles, big muscles, will be absent here. What is the weak place? Place which is lack some layers. Which layers is absent here? 2 muscles. They doesn't reach the level of ligament, doesn't fuse with it. Now you can see the biomechanism of formation of the inguinal space. 1 minute attention. But how the space will become to the channel? Space, it is only roof and floor of this channel. To form now completely the channel, we should imagine anterior wall, and we should imagine posterior wall. What will cover from in front all these structures? External oblique aponeurosis. Inferiorly, it will become to the inguinal ligament by its duplication. So my head, which I put in front of them, it is external oblique, which is inferiorly turning to the inguinal ligament. Yes or no? What is covered these structures from back, my blackboard? It is the deep layer of proper fissure, which is covered inner surface of transverse muscle, and which we call transverse fissure. By the way, in whole abdomen, it is called endo-abdominal fissure, because it is covered not only interior wall, but also posterior wall. So once again, how from 2-dimensional 2D space, we come to 3D space. 2D space, it is space between up and down. If I will add anterior wall and posterior, it will come to the volumetric structure. My anterior wall in front of internal oblique, I will have aponeurosis of it. Why I say aponeurosis? Because it is below bispinal line. What is located behind of the transverse muscle? Deep layer of proper fascia, which is called transverse fascia. That's all. Only we didn't draw up to now deep ring of the inguinal channel. How I can draw it? I will now find, friends, midpoint of inguinal ligament, and 1 centimeter up and laterally to it, I will draw half of the ring, another half covered by these muscles. And that structure number 8 in my picture, will be deep ring of inguinal channel. What is it? Aperture in the transverse fascia. What is my blackboard? Transverse fascia. We say that behind of these muscles we have transverse fascia. It is perforated. In your fetal time of the life, it is perforated. During the descending of testis, testis is descended from up to down, and it is perforated. Now you have complete inguinal channel by 2 rings and by 4 walls. Do you have any questions? No. I must put attendance. Number